Hello everyone. Today's topic is muscular dystrophy, right? So as we know, muscular dystrophy is a genetical disorder, especially DMD, Duchenne's muscular dystrophy is one of the most common and most severe form of all the muscular dystrophies. So DMD is a result of faulty gene. So a particular faulty gene that is known as dystrophin gene, which is responsible for DMD, right? And DMD is a sex-linked disease, and in this disease, males are affected and females are the carriers, as we know. So DMD is a fatal disease, and the patient usually survives till the age of 20 years, right? Death results from several cardiac and respiratory complications. And unfortunately, no treatment is available, which can really affect the loss of muscle cells. So, what we can do, the only thing is that we can only limit the ill effects of the disease by means of physiotherapy and other members of rehabilitation team. So basically, dystrophin gene is responsible to produce DMD, right? The gene and the gene product dystrophin has identified as a major cause of DMD because defect in a protein present in muscle fiber known as dystrophin. Dystrophin is a protein that presents in the inner surface of sarcolemma of the muscle fiber and is produced by the dystrophin gene, right? Now we discuss clinical features. The clinical features of the disease don't appear immediately in the postnatal period, but appear at the age of 3 to 5 years. After the development of features of the disease, a small number of patients with DMD will be with a minor functional deterioration, but a large number of patients will suffer from progressive deterioration of the body functions because DMD is a progressive disorder, progressive disease. So abnormal gait pattern, frequent falling, and difficulty in getting up from sitting and lying position. So these are the features of DMD, right? The patient comes to us with abnormal gait pattern, he falls frequently, and the patient feels difficulty in getting up, right? So these features are the basis for diagnosis of DMD. The gait pattern of a boy with DMD will be generally clumsy and show even before the age of 3 years, but it is usually not noticed. So after 3 years, we can notice the features, clinical features, and signs and symptoms. But at the age of 4, to 5 years, the waddling gait can be noticed in the patient along with the lumbar lordosis, right? So waddling gait is a common feature. It occurs due to weakness of abductors, bilateral abductors weakness. So for a boy of DMD, it is difficult to get up from sitting or lying position. So patient will stand up in a typical pattern, and this pattern is known as Gower's sign. Gower apostrophe S, Gower's sign, right? So Gower's sign is one of the diagnostic sign of DMD, and in this we observe the way the patient stands from lying position, right? So the DMD patient has a very typical scheme. Firstly, the patient goes in prone lying position from supine lying position. Then the patient will get up on his forelimbs as in crawling. Now the patient comes in quadruped position. Both the hands and the knees will be in the contact with the floor. Then the patient will extend the elbows and the knees and then draws the leg towards the body alternatively. So after that, moving his alternate hands, patient will hold the leg with the hands alternately. So then both the hands are moved towards thigh alternately. It means the patient like climbs on the thigh and then stands straight. So this is a typical pattern of standing from lying position. And this is the pattern of Gower's sign, right? So after a few days, condition of the body deteriorates and the patient is unable to jump up even a very small step. The patient feels difficulty in walking, running, jumping, right? So patient is unable to walk, run, and when he is told to run, he walks fast and then falls. So these are the clinical presentation of DMD patients. Climbing stairs also becomes difficult. Patient climbs stairs very slowly. Patient uses the strength of his arms to pull himself up. But some patients manage to climb stairs even after the age of 8 years. Next point is the muscle weakness. It starts by the age of 5 years. And the skeletal muscle weakness leads to majority of problems in DMD. Patient feels difficulty in performing his ADL, activities of daily living. Weakness causes the muscle to contract with less force and power, and the muscles of the lower limb are more involved than the upper limb. So weakness of the muscle starts in the proximal muscles of the lower limb, especially gluteal muscles, quadriceps, lower trunk muscles, and later in shoulder girdle. and then extends to the distal muscles. So proximal muscle groups will be involved first, then it will extend to the distal group of muscles. Next point is the muscle weakness is the main cause of cessation of ambulatory phase in DMD. In the early stage of the disease, the waddling gait results from weakness of proximal muscle of lower leg. Right? Sound is coming, na? सत्यम आवाज आ रही?
यस सर, यस सर,
Okay.
अभी आने लगी.
ठीक. So muscle weakness is the main clinical feature of the muscular dystrophy, right? So in young children, there will be hypertrophy in the calf muscle, enlargement of the calf muscle, and some other muscle group, and takes place due to accumulation of fat and connective tissues in the muscle. So muscle looks bulky, hypertrophy. So enlargement of the muscle due to fat or connective tissue deposition is called as pseudo hypertrophy, right? So contracture starts developing in later stage of ambulation due to position the patient which he adapts in order to balance in standing and walking. So the contracture develops, and this contracture will be asymmetrical and mainly affects the heel cord and TFL. So TFL tightness and tendo-Achilles tightness is common in muscular dystrophy patients, especially DMD. This contracture becomes apparent by the age of 7 to 8 years, right? So at the age of 8 years or 7 years, we can notice all the clinical features, signs and symptoms of the muscular dystrophy. So in the latter stage of the disease, the contractures are aggravated because the patient spends more time in sitting position. So as the patient is not able to walk, joint contractures develops at the hips, knees, and the wrist, and leads to large number of deformities. So deformities begin to develop, and the lumbar lordosis in early stage of the disease develops and is replaced by kyphoscoliosis. So spinal deformities, contractures, hip joint contractures, knee joint contractures, and ankle joint contractures are common in DMD patients. Scoliosis often develops because of the weakness of spinal muscles, right, which are unable to support the spinal column upright in sitting posture. So spine deviates laterally. It may deviate right side or left side because of trunk muscle weakness. It leads to scoliosis. Thus, scoliosis develops soon after the patient is unable to walk and is usually at the age of 10 years. Right? Next important point is ambulation of the patient stops completely between the age of 7 to 14 years. Right? Now the patient becomes bedridden or wheelchair bounded. So after the cessation of ambulation, the patient becomes totally dependent on the wheelchair, right? So after the patient has lost his ability to walk, he develops impairment of function in upper limbs and trunk also, right? The first lower limbs will be involved, especially proximal muscle group, then the trunk and the upper limbs. So prolonged sitting leads to impaired flexion of hip and extension of knee, and the muscles of forearm, arm, all these will be involved. So patient is usually confined to wheelchair by the age of 12 years, right? So now we can see the deterioration of the condition of the patient, right? Condition is deteriorating. It's a progressive disorder. So by the early teenage, muscle weakness becomes more extensive and the patient becomes dependent for his ADL, right? By the age of 14 to 18 years, patient develops severe pulmonary complications and sometimes fatal pulmonary infection. And sometimes fatal pulmonary infection becomes severe, and the presence of scoliosis and other chest deformities causes impairment in respiratory function and thus aggravates the pulmonary infections. Right? So we have to prevent the spinal deformities. So restrictive lung disease occurs due to weak diaphragm, chest, and abdominal muscles. Clear? Next point is the bone thinning and the pathological fracture may also take place because of osteoporosis, right? Because now the patient is non-ambulatory, the bone becomes very thin and osteoporotic. So faulty infiltration of the heart and the cardiomyopathy are fatal for the patient. So ultimately, death of the patient may occur anytime between mid-teenage to mid-20s. So the main cause of the death in DMD is chest infection, right? Next thing is bladder involvement and bowel symptoms we can also see in patients of DMD. Uncontrolled vomiting occurs in a wheelchair-bounded patients having lumbar lordosis. So lordosis exerts pressure over the superior mesenteric vessels on the third part of duodenum because the patient is going to spend maximum time on the wheelchair. So because of this posture, the superior mesenteric vessels on the third part of duodenum are pressed and causes uncontrolled vomiting. Right? Next important feature is psychological problems. So diagnosis of DMD is a heartbreaking news for the patients as well as the family members. So psychological counseling is very important to the patient as well as to the family members. Right? And the physiotherapy plays a very vital role to reduce the ill effects of the various neuromuscular conditions. So by using physiotherapy, we can lessen the complications. So every child suffering from a muscular dystrophy is different regarding his needs and abilities and requires an individual exercise program, right? So history taking and examination is the main part of this planning of physiotherapy treatment. So it must always be remembered that in spite of physiotherapists, parents are first to give help and support to achieve the right and firm relationship with their child during the treatment program. So due to this reason, it is also important to make friendly relationship with the parents to gain full cooperation and the maximum help from the family, right? Now we discuss physiotherapy. In children with DMD, increasing weakness makes a different task like walking, running, jumping, and dressing more difficult, right? Because the patient is unable to move, he cannot dress himself, he cannot walk, he cannot run, he cannot jump, etc. So patient feels difficulty in ADL, but there are ways in which a child can be helped to retain as much independence as possible without causing distress or without disturbing his educational and recreational activities. Means we have to motivate the patient to do activities. So there are so many goals we have to achieve by physiotherapy. The first one is to minimize the development of contracture. We can use physiotherapy. We have to educate the aerial techniques to the patient. We have to maintain the muscle strength of the patient by physiotherapy. We have to minimize and prevent chest complication by physiotherapy, and to prolong mobility and functions by the use of orthosis, wheelchair, and gait training. So we have to educate the patient as well as the family members regarding orthosis, wheelchair, and gait training. Right? So in this physiotherapy, passive stretching of the muscle helps a lot. Passive stretching basically maintains the muscle length. So to prevent contracture, we do stretching, passive stretching. If muscles are connected to bones by the tendons, while the ligaments control the extent or range of motion of the joint, right? So when the muscles becomes weak or not used, they lose their extensibility, and so the joint becomes stiff and tight, usually more in one direction than the other. So this leads to a fixed contractured position of the joint, which in turn leads to deformity in a limb. Clear? So contractures that occur frequently in a child suffering from DMD is at the ankles, knees, and the hips. So they are caused partially due to child walking on his toes with the knees bent and the feet apart. So the contractures are aggravated in the latter stages of the disease as the child spends more of his time in sitting position, right? So when the contracture develops in a joint, it also affects on the other joints also. It also affects on the spine, right? So passive stretching is a simple technique used to stretch the tight or shorten muscles by moving the joint slowly and firmly as far as possible. So the position should be maintained for about 30 seconds. During the above procedure, the child must relax completely and should not make any active movements. Right? So passive stretching should always be done properly and effectively to reduce pain. During passive stretching, there is a sensation of pull and pressure to the patient. If the passive stretching is done carefully and not aggressively, then the joint or muscle will not be harmed. Right? So while doing passive stretching, firmness and kindness both are essential. So gradually we increase the tension during stretching. Right? So it should be done every day and should become a daily routine of the patient. So it is the best applied after a warm bath when the child is feeling relaxed. So during stretching, the patient should be in relaxed position. The environment should be comfortable. So in order to get the better results, exercises are done in an atmosphere of fun, singing, and enjoyment. Next thing is tear tightness is the common presentation in DMD patients. So in order to stretch the foot, the infant is made to lie down in supine position. Right? The patient position will be in supine lying position. And the physiotherapist stands at his or her foot end at the level of feet. So therapist holds the heel of the left foot with the left hand such that the heel of child rests in the hollow surface of the palm. Now we are going to stretch left-sided tendo Achilles, right? Now with the right hand, hold the foot and try to dorsiflex. The foot hand, the knee should remain straight and repeat with the other leg, right? So if we want to stretch left-sided tendo Achilles, the therapist holds the heel with his left arm, left hand, and if we want to stretch right-sided tendo Achilles, the therapist holds the heel with his right hand. And we have to increase tension gradually, right? To give stretching. Next thing is for the knees, usually some contractures develops at the knees before the child is dependent on a wheelchair. Hamstring tightness is very common. So it is important to prevent contractures in order to decrease the difficulty of walking with bent knees. Right? So because of hamstring contracture, patient walks with bent knees. So to stretch the knees, the child lies in a supine lying position. Therapist stands near the side of the leg to be treated. Therapist places his hand and makes a grip on the heel, and with the other hand, pressure is applied downward on the thigh, just above the kneecap. Right? So while applying pressure to the thigh, the therapist lifts the heel to straighten the knee. Right? And the movement is repeated 15 to 20 times on each knee. When we stretch the hamstring, we hold at the end range for 15 to 20 seconds. Right? So stretching can be done while the child is lying prone. So during this, a small pillow is placed under the thigh. This is the another position. So in this, the patient position will be in prone lying position. We place a small pillow under the thigh, and this will allow the weight of the lower leg and the foot to straighten the knee joint. Right? So slight pressure can also be applied on the lower leg. So by doing this, we can stress the hamstring muscle by maintaining the posture. So one position is supine lying position, in which we stretch the hamstring muscle by lifting the leg up, right? And the other position is prone lying position. Ask the patient to lie down in prone position and place a small pillow under the thigh to stretch the knee, right? Hamstring muscles. Next common condition is hip flexion contracture. So in this DMD, hip will be involved. So the two main groups may be involved in DMD. One is hip flexors and another one is hip abductors. Hip flexors, iliacus and psoas major. These are the main hip flexor muscles. And the gluteus medius, minimus, and iliotibial band are the hip abductors. And the TFL also plays a accessory role. The hip flexors can be stressed by three phases. First we discuss one by one. And this, the child lies in a sideline position with the limb to be treated, facing upwards. The therapist stands behind the child and places one hand on the child's hip bone and the other hand under the thigh of the upper limb, just above the knee. Right? The lower leg can be kept either bent or straight. The therapist then draws the thigh backward towards him or her in order to stretch hip flexors. So in sideline position, we can stretch hip flexors. First, we have to stabilize the pelvic girdle. Then we support the thigh and we pull the leg backward to stretch the hip flexor. Right? So important thing is pelvis stabilization. So during this movement, the pelvis must be stabilized. Right? The other position is prone lying position. In that we can give stretching to the hip flexors. So child is made to lie down in throne lying position. Therapist stands near the side of the limb to be treated. The therapist places his or her one hand over the buttocks and the other hand under the thigh on the distal part. And then the thigh is lifted and thus extended so as to stretch the hip flexors. So in throne lying position, we can also stretch hip flexors. First, we have to stabilize the pelvis, and then we hold the thigh and we move the thigh upwards to stretch hip flexors, right? So by doing this, we can stretch the hip flexors. The patient position will be throne lying position, right? Next position is the child lies in a supine lying position and the opposite leg is brought up towards the chest. And in this position, either actively or passively, the therapist then places his hand over the knee of the leg that is to be stretched. It means the patient position will be supine lying position, right? And the therapist bends his opposite leg towards the chest, right? And stretch the involved leg. In this, the therapist applies a downward pressure, right, to stretch the muscle. Right? So these are the three positions: supine lying position, side lying position, and throne lying position. In this, we can stretch the hip flexors. We can also stretch hip abductors in supine lying position. We can stretch IT band in opposite side lying position, right? So basically, stretching helps to maintain the normal muscle length and it prevents contracture and deformities, right? Now we discuss upper limb. So contraction in elbows and wrist are common, but it does not develop in early stages of DMD. But when the child becomes dependent on wheelchair, then stretching of these joints can be done to prevent tightness, right? So elbow flexors, supinators, pronators, wrist flexors, all these muscles will be involved in DMD. So to stretch elbow flexors, the patient position may be sitting position or supine lying position. And the therapist holds the upper arm of the patient with one hand and with the other hand holds the wrist, right? And try to extend the elbow. It means we hold the arm and we hold the wrist to stretch elbow flexors, What are elbow flexors? Biceps, right? So it can be done in sitting position or it can be done in supine line position, right? Next one is stretching of pronator and supinator, right? Supinator, it helps in supination, and pronator, it helps in pronation, right? So therapist with one hand holds the upper arm of the patient and the with the other hand holds the hand of the patient as if shaking the hand. Now the therapist alternatively supinates and pronates the forearm, right? So first we stabilize the elbow. We hold the arm just above the elbow. Then we hold the wrist of the patient. Then we pronate and supinate, right? We stretch pronator and supinator. Clear? Next thing is for wrist flexor stretching, the therapist supports the forearm of the patient near the wrist joint, and then therapist moves the wrist backwards to extend wrist, right? By keeping his or her palm in contact with the palm of the patient, right? So first we stabilize the distal part of the forearm, right? We stretch wrist flexors. To stretch wrist flexors, we have to move in extension direction, right? So first we stabilize here, then we hold the hand of the patient, then we gradually stretch, right? So all these stretching techniques are important to maintain the normal length of the muscle in case of DMD patients, right? Next important thing is education of proper positioning and sitting, right? It is very important. So positioning and sitting enables the child to do his best function. If your posture is correct, you can do maximum activities with minimum effort. So to prevent spine and joint problems and to prevent pressure sores, we educate the patients, right? So main aim of teaching a good sitting is to minimize deformity and to provide support and to ensure comfort and to increase trunk control. So a good sitting positioning can be achieved by a good supportive seat in which all the parts of the body are supported correctly, right? So we can modify a wheelchair according to the patient's need, right? Next point is baby walker should always be avoided as they don't improve posture and trunk control, right? So we don't advise for baby walker. So while teaching a good positioning, good sitting positioning, the first thing taught is the maintenance of correct position of the pelvic girdle is important, right? Your seat should be proper and the pelvic girdle should be in neutral position. The pelvic girdle should always remain in upright neutral position without any anterior or posterior tilt. Right? So pelvic girdle should be in neutral position. Weight of the body should be distributed equally over both the iliac crest, and the patient is advised not to transfer his body weight over one iliac crest. Right? The body weight of the patient should go downward uniformly, and the anterior tilt and the posterior tilt of the pelvis, rotation of the pelvis should be avoided. Right? So when the pelvic girdle will be in neutral position, this will give you a upright posture. Right? So the next important thing that comes in is the proper and correct support for the whole body. The patient sits in a chair. The chair should be such that it supports all the body parts of a patient. Right? So while sitting, the chair back should only be inclined when the patient is tired and is relaxing. Means the chair back should support the whole back of the patient. The footrest should be of proper height so that it supports the feet and prevents it from dangling on the ground. The important point is the proper height of the footrest. Right? Next point is the length of the seat should support the whole thigh, and the adjustable back and the footrest of the wheelchair provide extra comfort to the body parts. Right? So all these comes in wheelchair modification. So according to the patient's need, we can modify wheelchair. Right? We can give proper support to the back of the patients. Right? We can support upper extremities. We can support a trunk by modification in wheelchair. Right? Next thing is we can give passive exercises. We can give active assisted exercises, and rested exercises according to the patient's condition. We can give exercises in sitting position. In sitting position, patient is made to sit on the edge of the chair or bed, right? And the chair or bed should be firm. Then he or she holds the edge of the bed or chair with his hands and pulls his toes and feet up by straightening the knees. So the pattern is same as that of kicking, and it should be noted that the child don't lean backwards and the knee should be kept straight. So this is for quadriceps rehabilitation. So once the straightening of the knee has been achieved, then resistance is given for the same exercise to strengthen the quadriceps muscle. And this resistance can be given by sandbag or by the weight or Manually, we can give resistance. Right? There are so many exercises in sitting positions, foot ankle exercises, knee straightening exercises, exercises for hip flexors, right? Sartorius functions we can check in this. External internal rotation of the hip joint in sitting position we can do. Upper extremity exercises we can do in sitting position, right? There are so many exercises we can do in sitting position. Exercise in side lying position. In this position, exercises is given normally for hip abductors and extensors, and the child is asked to do 10 to 15 times. So in order to prevent the child to come back in supine position, a firm pillow is placed behind the back. Now the child is asked to abduct his upper leg and slightly keep it backwards. It should be done for 10 to 15 times. Right? So hip abduction in sideline position we can do. Hip extension we can do in sideline position. We can do same exercises with the resistance by sandbags, or manually we can apply pressure. Right? In prone line position, we can give exercises for hip extensors, shoulder extensors, neck extensors, back extensors. Right? So to strengthen the hip extensors, we ask the patient to lie down in prone line position. Now we ask the patient to lift his one lower limb upwards, right? Then the other side. So while performing this exercise, patient to roll his pelvis, right? To prevent this, for shoulder extensors, we can use prone line position. For spine extensors, we can use prone line position, right? For neck extensors, we can use prone line position, right? There are so many exercises in supine line position. Flexion exercises along with knee flexion exercises, straight leg raising exercises, abduction, adduction, ankle movements, right? Some stretching exercises we can do in supine line position. So there are so many exercises we can prescribe to the patient in supine line position, right? Next important thing is chest physiotherapy. Chest physiotherapy plays a vital role in case of DMD. There are so many techniques we use, like postural drainage, breathing exercises, percussion, post expiration techniques, assisted cuffing. All these are used to improve patient's condition, right? What we do in postural drainage? Yes, anyone? Why the postural drainage is important? Why postural drainage is important? What is the significance of postural drainage in case of DMD? Anyone? Yes, Satyam. What is the role of postural drainage? Anyone? Anyone? Satyam, Shivani, Nancy, Mamta.
सर जो सिक्रीशंस होते हैं लंग्स के में
हम्म,
तो इन्फेक्शन ना कॉज करे इस वजह से हम लोग पॉस्चरल ड्रेनेज करते हैं.
राइट. ठीक है. So to drain the secretions, right? We use postural drainage. So basically, it is a technique in which the patient is made to lie down in certain positions. There are so many positions so that the gravity helps in drainage of secretion, right? And the most commonly used position are supine lying position, prone lying position, side lying, with foot end tipped to a certain degrees, right? So in this, gravity helps to remove secretion. It helps in drainage of secretion, right? Next one is percussion. Percussion is a technique in which gentle clapping over the chest is done with the cupped hands. So it helps to loosen the secretion, which can be drained easily by postural drainage. So the clapping should be done gently with the movements taking place only in the wrist, right? So percussion should always be done along with postural drainage to remove secretions. So technique is very important. So this movement should be done in the wrist only, right? So by using wrist movement, we can do clapping, right? So this is called percussion. Breathing exercises. These exercises are used in order to increase the air entry in the lungs. Breathing exercises also improves the strength, endurance, and coordination of respiratory muscles. Right? So some of the breathing exercises taught to the patient are diaphragmatic breathing exercises, segmental breathing exercises, right? Post expiration techniques. There are so many techniques of breathing exercises which can be taught to the patient. Now we discuss forced expiration techniques. Forced expiration technique. So in this technique, patient is asked to take a deep breath and perform one or two huffs followed by a cough. So we have to teach huffing and coughing technique to the patient also. So huffing helps to bring the secretion up to the throat, and cough helps to expel out the secretions from the throat. Right? So what is the basic difference between huffing and coughing? Anyone knows the difference between huffing and coughing? Yes, Sandhya, Piyush, Anupama, Anikant, anyone? Anshuman. The difference between huffing technique and coughing technique. Anyone? Anyone? Basically, huffing technique is done with glottis closed, right? And the coughing is done with the glottis open. So this is the main difference. So by huffing, we bring the secretions up to the throat, and the coughing helps to expel out the secretions from the throat, right? So huffing is achieved by taking a deep breath and then forcing the air out as rapidly as possible without, with mouth open, right? Next is assisted coughing. Coughing mechanism is generally not performed by a child with weak abdominal muscle. So in this case, manual assistance is provided by the therapist in order to perform a forceful cough. Right? Then assisted coughing. In this, the patient is in supine position and the therapist places his outer border of the hand on the patient's abdomen under the diaphragm. After the patient inhales deeply, the therapist assists the patient as he or she attempts to cough by compressing the abdomen by an inward and upward force, which pushes the diaphragm upward to cause a more forceful and effective cough. Right? So assisted coughing is especially beneficial in clearing secretions at the time of chest infection. Right? So these are the techniques we use to clear the lungs areas. Next important thing is arthrosis. It basically maintains the body parts in an anatomical position. It keeps the spine straight when we use spinal braces. So arthrosis are the external appliances which are worn to restrict or assist motion or to transfer load from one body part to another. So calipers, spinal jackets, braces, night splints comes in arthrosis. Right? So night splints can be given to the patient to be worn at night in order to prevent contractures. So night splints are usually necessary only for the ankles as there are great chances of developing contracture in ankle. So the splints given should always fit properly, must be comfortable, and should be light-weighted. So a splint given to the ankle starts from toes and reaches below the knee. The choice of the type of arthrosis to be given to a child depends on the severity of the deformity and the age of the child and fitness of the child. So proper assessment and evaluation of the body part is must before giving an arthrosis. And the arthrosis should be light-weighted, comfortable, and properly fitted to the child. Right? So in DMD, the common arthrosis used in lower limb is KAFO, that is knee ankle foot arthrosis. Right? In case of scoliosis, TLSO can be given, thoracolumbolosacral arthrosis. TLSO should be given to a child as soon as he is bound to the wheelchair. The lordotic position of the lumbar spine of TLSO helps to lock the posterior articular facets and thus prevents scoliosis. For prevention of scoliosis, we can prescribe TLSO, that is thoracolumbocervical arthrosis. Right? Next is wheelchair. It's a mobility arthrosis. It makes the patient independent. Right? So in order to supply most suitable type of wheelchair to the patient, the therapist should do proper assessment of the patient and give advice to the patient and make any adjustment if required. So we can modify wheelchair according to the patient's condition. So usually a self-propelled wheelchair is given to a child as this increases the chest expansion and muscle power of the upper limb. And the self-propelled wheelchair can be used at the home. So for outdoor purposes, attendant propelled wheelchairs are used. When the patient is unable to use the self-propelled wheelchair in later stages of the disease, then powered wheelchair or attendant propelled wheelchair can be used. Right? So like an arthrosis, a wheelchair should also fit correctly. It should be lightweight, strong, and have a cosmetic look. Right? And wheelchair should provide a good sitting position to the patient, leaving minimum space on either side of the sitting area. Right? Means wheelchair should be compact. To prevent equinus position, the feet should be supported at 90 degree by the footrest. Right? So angle between the thorax and the hip should be 90 degree. The angle between hips, thighs and the knees or lower leg, angle should be 90 degree. And the angle should be 90 degree in between the lower leg and the feet. And the armrest of the wheelchair should be at the proper height so that when the elbows rest over the armrest, the shoulders are in a relaxed position. Right? So a waist strap is fitted in a wheelchair for extra safety of the patient. Right? Because the trunk muscles are weak in DMD patients, so he can lean forward. To prevent this, we can use a waist strap. Right? So when the child becomes dependent on the wheelchair and uses the wheelchair for most of the day activities, then certain modifications in the wheelchair become necessary. And these modifications prevent the development of other deformities which may arise due to the postural defect. So as the child sits continuously in a wheelchair, certain modifications are must for surface of the seat, right? So the seat surface must be firm to provide support to the pelvis and maintain it in the level. So the firm base of the seat is achieved by keeping a hard board under the cushion of the seat, and this hard board decreases the sagging effect of the cushion and thus maintains the better posture. But you have to check the skin conditions also. So if next point is, if the width of the seat is too wide, then both sides of the wheelchair are padded, and padding helps to keep the pelvis in center and straight, and it also supports the hip. So when padding is used, it is necessary to extend the arm pads of armrest inwards over the side pads, and this will eliminate sideways leaning of the patient to gain support from arm pads. Right? So we can use side pads to prevent leaning sideways. So to provide stability and to maintain a good sitting position, the knee should always be kept at 90 degrees, the thigh fully supported and foot placed in 90 degrees. A wide strap is fitted behind the calf in the wheelchair to prevent patient to pull his feet backwards. A similar strap can be used behind the foot plate to prevent foot drop. Right? Next important point is the backrest of the wheelchair should be high enough to support the shoulder, and the backrest should form nearly 90-degree angle to the seat of wheelchair. Should encourage spinal extension of a lumbar pad can be used. Proper padding is done to minimize pressure effects of the TLSO. The TLSO in later stage causes much problem and is exchanged by the various forms of cushioning which is fitted in the wheelchair. Right? So as the muscle power becomes less, the patient is unable to gain stability in the wheelchair. In such case, lateral support is required. Lateral support is a curved metal plate which is fitted to the backrest. If the head control is poor, then the head support can be given by adding headrest to the wheelchair. So the function of the hand and the arm can be assisted by the arm supports or by adding a tray to the wheelchair. It means we can modify wheelchair according to the patient's condition. Right? So this is all about DMD, Duchenne's muscular dystrophy. Any questions you want to ask? Any questions related to this chapter?